And we're ready to roll. Hello everyone, and thank you for joining us for the third part of our multi-learning webinar series, The Psychiatry of Pandemics. My name is Pospo, and I hope you're all keeping safe wherever in the world you happen to be watching this from. I happen to be in my office here at King's College Hospital in London. Okay, I could do with something more sunny and exotic, but not for the time being, as the lockdown continues strong, at least here in the UK. So last week, we explored past outbreaks of coronaviruses with the one and only Dr. Jonathan Rogers. And we did indeed establish that although the SARS-CoV-2 is a virus that has a particular interest for your lungs, it is also neurotropic and can indeed have a wide range of neurological and neuropsychiatric complications. So what do you do about it? Do you just stand there and just watch? Or what about the psychiatric disorders we've been treating so far? Do we continue with business as usual? And what do all doctors do when we are uncertain? Well, call the pharmacist. Dr. Siobhan Gee, ladies and gentlemen, a principal pharmacist here at the Maudsley. She has worked with a diverse range of teams, including the National Psychosis Unit, where she developed a really specialist interest in treatment-resistant schizophrenia. And yes, she knows everything about clozapine, but not only. Having decided early on in her career that, well, humans are way more interesting than petri dishes and micropipettes, she moved from Pfizer to the Maudsley and is now a liaison pharmacist, a specialist in the use of psychotropics in people with other comorbid health conditions. Always ready, I have to say, to correct me in nanoseconds every time I wrongly become, let's say, a bit too generous with my doses. 20 papers, 4 book chapters, a contributing author to the Maudsley prescribing guidelines, and 2 children. Siobhan, you must be extremely busy.
Always extremely busy, Pospo.
So welcome, Siobhan. But before we get to the nit and grit of the pandemic, I think it would be really helpful if we clarify this once and for all. Because yes, we may be extremely lucky to have you here at King's, but I doubt that everyone has access to a pharmacist whenever they want to. So what is the role of a pharmacist in a multidisciplinary team?
To be the drugs expert, to interpret the research evidence, to get safe and effective drugs rapidly to patients. And where there isn't evidence, to provide expert opinion and pragmatic advice.
Wow, okay, so but has this changed in the last couple of months? I mean, has the pandemic affected you in any shape or form?
I mean, absolutely. So it's my job to rapidly interpret clinical data to provide evidence-based treatments for patients. But the concepts of rapidly and evidence-based have become somewhat stretched. So rapid certainly took on a whole new meaning. It's been very pressured to interpret what little evidence there was and work out how that was relevant for our patients and for our drugs. Because there's still no real direct evidence about COVID-19 and psychotropics. So it's all based on application of what evidence there is and expert opinion. And frankly, no one was, certainly 6 weeks ago, an expert in COVID-19. So that's the real skill of a clinical pharmacist. Anybody can read the textbooks and the guidelines, but it's my job, it's our job to interpret them into application to real patients who never fit the guidelines and never fit what you read in a textbook.
Sounds really hard, and I can only imagine, but you know what? The thing that I cannot really imagine is how it would have felt to be a pharmacist in, let's say, for example, the 1918 flu pandemic. So how different were things back then, do you think?
Gosh, well, I mean, the first antipsychotic didn't arrive till 1950, so probably not much of a specialist role for a mental health pharmacist. But you'll be interested, possibly, because I actually did find an article in a journal called The Druggist's Circular. I'm a bit disappointed that I'm not called a druggist anymore, which said that the epidemic, and this is the 1918 epidemic, made a deep impression on the drug business. So they said that druggists are no more immune to influenza than other people, and are overworked to a degree believed to be unprecedented. So that certainly feels pretty familiar. And in fact, back then, just the same as today, they had panic buying, not of toilet paper, but of salicylate, which of course is aspirin, and an interesting mirror of modern times, also of quinine. And this article also notes that the other parts of the pharmacy business were neglected. So that back then was the cosmetics counter and the soda fountain. So no Boots meal deal during that epidemic either. But they did also feel that some good came out of the 1918 flu pandemic for pharmacy. So they say it served to establish in the estimation of the public the practice of pharmacy as a profession, that pharmacists saved lives, many lives, is indisputable, and that they conducted themselves with conspicuous and self-sacrificing devotion to duty and to humanity is equally conclusive. And now I know that all my colleagues have been working extremely hard over the past couple of months, so I'm sure the same is going to be proved true in our current pandemic.
So fast forward to now, and the world is being assaulted once again by coronavirus. But what is it you think that makes this particular virus so special, obviously from a psychopharmacological point of view?
Yeah, so there are two categories of things here. The first is, what does it do to patients that means that those taking psychotropics might be more at risk? So it's a respiratory disease, and some of our drugs are respiratory depressants. Our drugs cause lots of metabolic side effects, cardiometabolic side effects, which can worsen outcomes in pneumonias. And then secondly, are there direct interactions with the effects of any of our drugs? So COVID-19 appears to cause blood dyscrasias, so we immediately think of clozapine. Acute kidney injury, so we think of lithium. Myocarditis, so we're concerned about clozapine and other antipsychotics again. Now, of course, we need to think of all illnesses and their relationship to the drugs that our patients are taking in this way, but this has been more challenging because this coronavirus arrived very quickly and we didn't, and in fact, we largely still don't know really very much about it. So we've had to interpret what limited data we do have, do some extrapolation from similar diseases, and a fair amount of guesswork, expert guesswork.
So, looking into the main symptoms of COVID-19, I mean, fever, cough, fatigue, I can almost hear my mom, hi mom, she's saying, okay, I got this, ibuprofen, and handing me over, tablets. So in mid-March, though, the French Health Ministry, they warned against the use of non-steroidal anti-inflammatory drugs to treat the symptoms of COVID-19 after 4 people with this disease and no underlying health problems reportedly developed serious symptoms after using non-steroidal anti-inflammatory drugs. So where do we stand in that respect?
Okay, so this theory was based on 4 things. Firstly, on the observation that infection with chickenpox and some other bacterial infections can be made worse by taking ibuprofen. There are also some concerns that the anti-inflammatory effects of things like ibuprofen may hide a worsening infection. It's true that ibuprofen may stimulate ACE2 receptors. And finally, in some ways, NSAIDs are immune suppressants, so they inhibit prostaglandins and the action of neutrophils. Where we stand at the moment is that there really isn't sufficient evidence to suggest that patients who take ibuprofen or other NSAIDs have more susceptibility to contracting COVID-19 or to developing a more severe illness. So look, pragmatically, if you can avoid prescribing an NSAID, then do so, but don't stop long-term NSAIDs, which include things like low-dose aspirin and NSAIDs for rheumatological indications. So if I had a headache, I would take paracetamol at the moment, but if I'd had a heart attack, I would definitely still keep taking my aspirin.
Touch wood. So with the risk of oversimplifying an extremely complex process, it seems that the coronaviruses, they invade our poor little cells by binding on the angiotensin converting enzyme 2 receptors. So there have been several experimental studies that show that the ACE inhibitors actually increase the number of these receptors, meaning that actually what's happening is that they create more playground for the SARS-CoV-2 to do its dirty job. So does this mean that patients on ACE inhibitors, and these are a lot out there, given that the ACE inhibitors are commonly prescribed for things like high blood pressure, so are these patients maybe at an increased risk of worse outcomes after COVID-19?
So, as you say, ACE2 inhibitors are the binding site for those spike proteins on the exterior of the coronaviruses. And it's those receptors that COVID-19 anchors to in the lower respiratory tract in order to gain entry into the lung. Now, people who are taking ACE inhibitors or angiotensin II receptor blockers are assumed to have higher numbers of those ACE2 receptors in their cardiopulmonary systems. That's based on animal data. So the concern was, as you say, that higher numbers of the ACE2 receptor would mean increased susceptibility to COVID-19. Now, there were increased concerns over this because data from China was showing that patients with hypertension, coronary artery disease, diabetes, chronic renal disease were getting more severe COVID-19, and those comorbidities would be indications for taking an ACE inhibitor. But we don't know what those patients were actually taking. There are also no studies that address the potential benefits or harms of initiating ACE inhibitors or ARBs as treatments for patients who've currently got COVID-19. And Pospo, I was going to say two more things. The first was that there are no studies designed to directly assess whether or not ACE inhibitors increase the risk of acquiring COVID-19. And also that after adjustment for confounders in the studies that we do have from China largely, a history of having an ACE inhibitor or ARB use wasn't found to be associated with increased severity of COVID-19 illness. So we had no evidence for those things. But hot off the press last week from the New England Journal of Medicine is a retrospective study of 12,500 patients in New York. And they showed that it's true, there was no association between taking one of these drugs and testing positive for COVID-19. And there was also no association between taking the drug and having a particularly severe course of COVID-19. What we definitely do know is that in the population of patients with heart failure with a reduced ejection fraction, these drugs are essential for reducing both morbidity and mortality. Their use is supported by over 30 years of clinical trial data and real-world data. And moreover, we know that there's evidence demonstrating that withdrawal of ACE inhibitors is associated with higher rates of mortality and hospital readmission. So it's really a very clear message. Patients should keep taking their ACE inhibitors.
That's really clear. Okay, so let's switch now to proper psychopharmacology. I mean, whether we like it or not, one of the most commonly prescribed classes of medication in psychiatry, not that we have too many to be fair, are indeed the benzodiazepines with their myriad uses and applications. Now, we do know, though, that they have been linked with respiratory depression. And then, on the other hand, you have people suffering from COVID-19 that relentlessly attacks their lungs. So what do we do then? Do we still prescribe benzodiazepines?
Respiratory depression. So benzos do not cause respiratory depression in therapeutic doses. In actual fact, they don't usually cause respiratory depression in overdose unless you also take them with alcohol or other drugs. There is an obvious concern that they might cause respiratory depression in patients with existing respiratory compromise. So for example, in COVID-19, and you would reasonably expect that risk to be higher in people with existing respiratory problems, so COPD, for example. Now, we don't have data for COVID, but we do for other respiratory illnesses like pneumonia, and we do for respiratory diseases like COPD. And those data actually are conflicting. So some find no association between benzos and increased hospital admission or blood gas impairment in patients with respiratory disease, and others do find increased exacerbations. But acutely, benzodiazepines are pretty unlikely to cause a respiratory depression.
And what about the people in the community? I mean, there was this paper from back in 2012 where the researchers looked into the use of benzodiazepines in the community and the risk of acquiring pneumonia. So can you tell us a bit more?
Yeah, so pneumonia is a separate thing. So chronic benzodiazepine exposure is associated with an increased risk of developing and dying from pneumonia. You get this increased susceptibility to infection via activation of the GABA A receptors on immune cells. And also, of course, increasing sedation increases the risk of aspiration pneumonia. So I've said that acute use of benzos doesn't usually cause respiratory depression, but chronic use does increase your risk of pneumonia. So most of the known risks with benzodiazepines apply to chronic use. So therefore, probably acute use, and you work in liaison in psychiatry, we're often talking about rapid trank or delirium with these questions. It's probably not a big risk, but it's an understandable concern. So again, I would take a pragmatic approach. If you can use a non-benzo sedative first, do that. If you can't, then use a benzo, but pick a short-acting one, so probably lorazepam. Use it in the lowest possible dose and for the shortest possible time, which of course is good practice anyway.
Yeah. But can we do though anything to arm our people, our patients, against a coronavirus infection? I mean, I remember in the early days of the lockdown, there was an email that was circulated in the trust suggesting that we should all be prescribing vitamin D. So is there any evidence for that?
Yes, and increasing amounts actually. So vitamin D supplementation enhances the function of the immune system. It reduces the risk of developing a respiratory infection. And vitamin D also affects the expression of that ACE2 inhibitor, the ACE2 receptor. So treating vitamin D deficiency to reduce respiratory infections has a number needed to treat of 33. That actually drops to a number needed to treat of 8 in a severe deficiency. So you reduce that risk of severe respiratory infection from 60% to about 30%. And there is increasing evidence that high levels of vitamin D are associated with a lower severity of that respiratory infection, actually including now COVID-19. So there are recent data from an Indonesian study showing very clearly a strong association with insufficient vitamin D and mortality in COVID-19, which may help to explain some of the increased risk for people of BAME backgrounds and who work in jobs that are inside or at night, so your bus drivers and security guards. We also know that people with psychosis are at particularly high risk of vitamin D deficiency. So as many as 85% of community psychosis patients have been found to be vitamin D deficient. So our recommendation, and this is thanks to Professor Taylor, Dr Cochrane, Eramona Whiskey at the Maudsley, is to give vitamin D supplementation to all patients with psychosis.
Fantastic. So, there was this smart paper. So Yi-Chun Cheng and his team, so they estimated the prevalence of acute kidney injury, AKI, in patients with COVID-19 in China. So what they found was that 1 in 20 patients, they did have acute kidney injury. And patients with kidney disease had a significantly higher risk for in-hospital death. So what does this mean for patients, our patients on lithium, a medication that's well known for its narrow therapeutic range, but also its love-hate relationship with the kidneys?
Yeah, so lithium is exclusively excreted by the kidneys. So therefore, in AKI, you are likely to see a sudden increase in lithium plasma levels. Additionally, lithium is associated with this gradual decline in kidney function. And as you say, chronic kidney disease has been associated with poorer outcomes in COVID-19. So that means that the risk for your patients on lithium is twofold. You have the acute risk. So if you develop an acute kidney injury during your COVID-19 infection, and this leads to lithium toxicity, and you also have this increased risk of serious complications if your lithium prescription has caused your kidney function to decline in the longer term. So if your patient's taking lithium, you need to remind them of the signs of lithium toxicity. so your diarrhea, vomiting, feeling acutely unwell, and that they need to make sure they maintain their fluid intake. For your lithium patients who have COVID-19 symptoms, I would take a lithium in plasma level. You need to be watchful for kidney injury and be prepared to reduce the dose if required. But the really key message is that people should not stop lithium abruptly, or really at all, actually, if possible. So stopping lithium suddenly risks a rapid deterioration in mental states, especially in patients who are prone to mania.
Fantastic. So don't stop lithium. So during our last webinar with Dr. Jonathan Rogers, hi Jonathan. So we discussed in great detail, I have to say, the neuropsychiatric effects of the coronavirus. So we do now know that delirium is one way that the SARS-CoV-2 may impact our central nervous system. So any particular recommendations we should bear in mind when managing delirium symptoms in patients with COVID-19?
You don't need a pharmacist, Pospo, for delirium management because drugs don't treat the delirium, they make it worse. So that's the end of my answer. Well, actually, I'm not joking. The recommendations largely remain the same. Don't use drugs. So medication should only ever be used in extremis in delirium for direct targeting of specific symptoms where they're really distressing to the patient or the patient is presenting unmanageable risks to others. So broadly speaking, I mean, antipsychotics are still first line, and those who can't tolerate antipsychotics can have benzos, but be aware that benzos worsen the course of delirium.
So, you know, even before we started doing the webinars, among the first questions that people have been sending me was, what do I do with my patients on clozapine? And here I am with you, a pharmacist that has spent years at the National Psychosis Unit, a scientist that has actually devoted her PhD on clozapine. So, you know, I feel obliged to ask, what do I do with my patients on clozapine?
So you make every effort to keep them on the clozapine. Clozapine is a uniquely effective drug. Stopping it is very likely to lead to relapse. That is the key message. Then I think there are two categories of question here. The first is, are my clozapine patients more at risk from COVID-19? Either are they more likely to get it, or are they more likely to get sicker with it? And then what do I do with my patients who are on clozapine and who are COVID positive? So firstly, I think clozapine patients probably are more at risk from COVID-19 than others, but mostly not because of the clozapine itself, but because it's unfortunately pretty uncommon to have a patient on clozapine who has no metabolic comorbidities. Patients taking clozapine for reasons of the treatment-resistant schizophrenia itself and the side effects from the drug are very likely to have multiple comorbidities that increase the risk of complications from COVID-19. So that's your obesity, cardiovascular disease. And we know that respiratory disease is particularly strongly linked to psychosis. So 1 in 5 deaths in schizophrenia are attributable to respiratory disease. Mortality from pneumonia in schizophrenia is 3.8 times that of the general population, and clozapine is particularly associated with a pneumonia compared to other antipsychotics. So your patients taking clozapine may well be more likely to get COVID-19, or at least to get a superimposed pneumonia with it, and to have severe complications because of associated comorbidities. So in order to minimize those risks, we should be making sure that we treat comorbidities or side effects as robustly as possible, including things like hypersalivation, which may increase the risk of aspiration pneumonia. The pneumococcal and influenza vaccines are probably a good idea, and you should certainly treat vitamin D deficiency. So that's the general risk. Then for your patients who are on clozapine and are COVID positive, there are some specific considerations for clozapine. The first papers that came out of China describing patients with COVID-19 showed that some patients were developing a leukopenia, so low white cell counts. But what's actually happening is a lymphopenia. Neutrophils are either normal or slightly raised. Now, the risk that people always remember with clozapine, if they remember nothing else, is that we have to do long-term blood testing. And of course, that's to manage the risk of a clozapine-induced neutropenia, which can progress to agranulocytosis. So patients presenting with low white cell counts in the context of COVID-19, you need to focus not on the total white cell count, but on the neutropenia, if there is one, or on the neutrophil count in general. And patient context is also really important. So more than 80% of clozapine-induced agranulocytosis occurs in the first 18 weeks of treatment. After that first year, the risk is comparable to any other antipsychotic, and in fact, to most other drugs. So blood dyscrasias in long-term clozapine patients are actually highly unlikely to be clozapine-induced, which is why at the Maudsley, we've also recommended that patients who've been taking clozapine for a year or longer can safely have a reduction in the frequency of their blood testing in order to reduce the risk of transmission of COVID-19. So that's blood dyscrasias. Plasma levels. So fever and rises in CRP, which is indicative of a systemic inflammation, can cause a reduction in the metabolism of clozapine through CYP1A2 liver enzymes. Additionally, patients with a respiratory illness may stop or reduce their smoking, or may be less able to efficiently inhale cigarette smoke, and that's also going to cause clozapine plasma levels to rise. So patients who are presenting as severely unwell with COVID-19, I would recommend they have a clozapine plasma level taken, and you need to be prepared to reduce the dose. And finally, don't be blinded by COVID-19 diagnostic overshadowing. Patients presenting with flu-like symptoms who take clozapine must still be investigated for myocarditis, neutropenic sepsis, if these things fit with the time course of the clozapine therapy. So the overall aim, again, for patients, all patients, including those who are COVID positive, is to continue the clozapine. Pay particular attention to neutrophils, look out for plasma levels, expect them to rise, and don't lose sight of the other adverse effects associated with clozapine.
Wow, I mean, that was a definition of a thorough answer. So moving away from clozapine to depot medication and long-acting injections. You see, one of the main concerns that I had early on in our journey through this pandemic was adherence. So how long are people going to stick with their usual medication regime under these new circumstances? In a recent paper on, I think it was schizophrenia research by Tanya et al., it is noted that the switch from long-acting injections to oral formulations was requested by patients or caregivers to reduce the number of trips to pharmacies and health centers. So what are the associated risks, and is there any other way around this?
Yeah, so I mean, this should be fairly straightforward, actually. There are things we can do to reduce the number of times depots need to be administered without risk to the effectiveness of the drug regimen. We just need to remember our basic depot pharmacokinetics. So the dosing interval of the depot should be increased wherever possible. So instead of weekly or 2 weekly dosing, you can increase it to 4 weekly. And remember, a longer dosing interval doesn't reduce the effectiveness of the drug so long as the overall dose remains the same. So patients on monthly paliperidone can be switched to 3 monthly long-acting injections. But I think the important thing to remember is that we mustn't allow a reduction in depot dosing frequency to mean that patients are not reviewed. So that was a common concern when the 3 monthly depots came to the market. But hopefully you don't need to stick a needle in a patient in order to make an appointment with them to talk to them. And the same goes for clozapine patients. So if we aren't seeing people every month for a blood test, we must make sure that we're talking to them with the same regularity in some other way.
Really important point. Reaching the end, psychopharmacology is a really beautiful word. I mean, whenever I am teaching psychopharmacology, I ask the students, what does the first word mean? Psyche, Greek word. So most of them, they say brain, they say mind, but nearly nobody knows that in fact, psyche means soul. So the pharmacology of the soul. So in fact, Siobhan, you are a soul chemist. That is, of course, if you believe that the soul resides in the brain. If not, then we are implying that we are just giving people an object, a pill, that people swallow, that goes and acts somewhere else, outside the body. So Siobhan, for the £2 million, is psychopharmacology the final nail on the coffin for the mind-body dualism supporters?
Well, firstly, I think soul chemist is going to be my new performing name.
Yes.
I'm all about the drugs, Pospo. But psychopharmacology undeniably, I guess, goes beyond the neurochemical effects. Otherwise, I don't know how you can explain placebo and nocebo effects. So how patients feel about the drug you're giving them certainly has an effect on what the drug does to them. So how you prescribe is important, as well as what you prescribe. So ultimately, I'm a druggist, I'm a soul chemist, but I don't do the talking and thinking bit. That's your job. But I reckon you can probably have your final nail in the coffin.
Thank you so much, Siobhan. That was a proper eye-opener. Congratulations also on your recently accepted paper. So if you are interested to read more on all things clozapine and COVID-19, head to Therapeutic Advances in Psychopharmacology for Siobhan's article, which is due to be published at some point this or next week. If, on the other hand, you have a thirst for more neurological and neuropsychiatric complications of COVID-19, head to the Journal of Neurology, Neurosurgery and Psychiatry, JNNP for short, where there is an excellent blog curated by our own Matthew Butler, Tom Pollack, and Tim Nicholson, among others. It is constantly updated with the most current publications and highlight key papers that you should be aware of. As long as we are concerned, we will be seeing each other again, yes, next Tuesday at 1 p.m. sharp for the fourth webinar of our series, The Psychiatry of Pandemics. With me, a very special guest, Professor Michael Erickson Benros, all the way from Denmark. He will be sharing wisdom distilled from these beautiful national registers they have down there in Denmark, but also at last answer the question, what is immunopsychiatry? And how relevant is immunopsychiatry with the COVID-19 pandemic? Pospo, for Monster Learning, over and out.